Imitation is the highest form of flattery. And so there's going to be a fair amount of overlap with Alice's wonderful presentation. I have just one conflict of interest. So PSMA, as we know, is a surface protein that's overexpressed in prostate cancer, especially in higher grade hormone refractory and metastatic disease. And when this is internalized, it can be retained and then be good for imaging as well as for therapeutic applications. And a tracer is a protein that's injected into the patient. Then a PET scan is done, and then you can detect localization of tumors. And there's lots of different applicability for this, for treatment planning purposes, detecting metastasis, recurrence, and eligibility for treatment, as we all know. So if we go back a little bit in time and we look at this study, which is really looking at the pro-PSMA study, looking at how does PET-PSMA compare to conventional imaging. And so they had 302 patients which got conventional imaging with CAT scans and bone scans, as well as the gadolinium 68-based PSMA PET scan. And then there was an analysis. So patients got both imaging studies. There was an improvement in accuracy with the PET PSMAs of 92 versus 65%. And then in terms of, did this make a difference in terms of management? So for example, 28% of the patients who had PET PSMAs, there was a change in how the patients were managed. There were less equivocal results in the PET PSMA imaging patients, and there was less radiation exposure. So the conclusion was that there was increased specificity of 98% versus 91, and improvement in sensitivity as well. Off note, we were just looking at the sensitivity of some of the other agents, and it's significantly lower compared to this study, but this did not require a histopathological evaluation. These are some of the common tracers that are used: the gadolinium 68, ILGO6, and Plerify and Post-Luma, and then PSMA 1007. They each have some different excretion mechanisms, and that can be helpful in deciding which agent might be the best to use. There's actually different guidelines for when is PET PSMA good for staging purposes, and we can see that it's really not indicated for low risk or for favorable, but for unfavorable and for high risk, there's a role. And it's also of note that current protocols like NRG 009 still uses both conventional CAT scan, bone scans, as well as allowing PET PSMA scans. But the stratification in terms of those studies, for example, if there is a bone lesion seen only on PET PSMA, it would still be eligible for the study if not seen on conventional bone scans. So I think important to note that in current trials, the conventional imaging is still allowed. And we looked at, Alice just showed us these 3 different studies that showed for very good specificity, 97, 95, 96%, and relatively low sensitivities. Here is another study that specifically was looking at the different tracers and seeing which one might be better. So this is the gadolinium 68 versus the 18F1007. So in this study, there were 244 patients that were retrospectively analyzed. And the conclusion is really there was a non-significantly higher PET positivity for the PSMA 1007, but there was actually greater rates of uncertain findings and false positivities. And overall, this was an international study. They found that the gadolinium 68 was more cost-effective as well. Here is a more recent meta-analysis that was just published earlier this year. And this was, again, looking at gadolinium 68 versus fluorine 18 tracers. And so this was performed looking at 24 studies, and their conclusion was that the Plerify was observed to be similar to gadolinium 68, but was maybe less preferable due to its high benign bone uptake. But overall, the conclusion was that there was not enough evidence to differentiate between these different radio tracers. So, what's the conclusion? I think that there is no definite evidence at this time that one agent is clearly superior to the other. But if we go back to how some of these agents are excreted, for example, Posluma may have a benefit over Plerify because there is lower bladder excretion. And so, if you're concerned about local recurrence or trying to visualize the prostate after a prostatectomy, this might be an agent that could show more because the bladder uptake would not be hidden in a sense. There were other studies looking at Spotlight, for example, and Condor, which were not, it's hard to compare them to directly, but it looked like that there was a higher rate of image detected recurrence for the Posluma compared to Plerify, with the PSA was less than 0.5. So I think overall, my conclusion would be that all the agents are still available, but maybe in specific instances like to look more at the prostate bed or prostate area, there could be some benefits. Thank you.